तुम हिंदी या तेलुगु?
मेरा
ठीक है।
कर्नाटक है सर, प्रॉपर।
ठीक है, ओके, लाइव स्ट्रीम हो रहा है ना अभी?
सर वही लाइव कर रहा हूँ, अब 1 मिनट में लाइव हो जाएगा।
ठीक है।
ओके सर, लाइव हो गए, देखो। वी कैन स्टार्ट।
ओवर टू यू नवीना।
Good evening, everyone. Welcome to the Journal Club of this month of August. Today, we'll go through this paper on changes in quality of life 1 year after intensive care. It's a multi-center prospective cohort of ICU survivors. We have Dr. Srinivas Amavedam sir and Dr. Gansham sir joining us as moderators. To take us through, we have Dr. Ganga Bhavani from Citizens Hospital, and I welcomed her guide, Dr. Bharat from Citizens Hospital. Over to you, Dr. Ganga Bhavani.
Good evening, everyone. I'm Dr. Ganga Bhavani, the R&B resident from Citizens Hospital. So today I would like to speak about Monitor ICU study. So before going to the Monitor ICU study, I would like to emphasize the need for Monitor ICU study. With recent advances and in the critical care medicine, survival has improved. But however, there has been they have been raised in the incidence of PICS. So what is PICS basically? So Society of Critical Care Medicine has defined PICS as a new onset or worsening of impairment in physical cognitive health that arose after ICU and persisted beyond hospital discharge. So there's also a term called as PICS family, which has been applied to the family members of the survivors of ICU who suffer with the same symptoms of PICS. So coming to the phases of critical illness, the acute illness usually vary from days to weeks. Hospital recovery, it will vary from days to weeks, and early post-discharge recovery can last up to months. And the most important period to decrease the incidence of PICS is during the ICU stay and the post-discharge recovery. So preventive measures taken during the early post-discharge recovery can decrease the duration of post-discharge recovery. If the measures have not been taken adequately or the preventive measures are not enough, then the the recovery can last up to even years. Now, what constitute PICS? PICS can happen in the survivors, and also PICS can happen in the family as well. So in the survivors, it has components which includes physical impairment, cognitive impairment, and mental health. In the PICS family, family members can suffer from anxiety, post-traumatic stress disorder, depression, and complicated grief. As the family members spend a lot of time taking care of the patient, and they may even quit their jobs, or even they may have gone to the jobs only for a short period of time as they have to take care of the family. So all these can lead to a financial burden to the family members, and it can lead to PICS family. So in the survival PICS, physical impairments mainly includes ICU-acquired weakness, whereas cognitive impairments includes memory disturbances, visuospatial disturbances, and in mental health, it includes anxiety, post-traumatic stress disorder, and depression. Coming to the risk factors of PICS, we have modifiable and non-modifiable risk factors. So by by um, uh, considering the risk factors which have been in the ICU, by modifying the risk factors which can be modified, the prevalence or the incidence and the of PICS can be reduced, and the duration of recovery period can be reduced. So coming to the non-modifiable modifiable risk factors, these are mainly patient risk factors, and the modifiable risk factors are mainly risk factors which can be modifiable in the ICU, like by reducing the duration of sedation, and also by decreasing the duration of mechanical ventilation, and by preventing hypoxia, by preventing hyperglycemia. So SCCM is suggest a post-discharge visit, that is after 2 to 4 weeks of discharge. If a patient visits a post PICS clinic, then the patient issues can be assessed and the incidence of PICS can be reduced, and thus leading to a decrease in the post ICU, decreasing the incidence of PICS and also decreasing the post ICU recovery period. So coming to the assessment tools in the PICS, we have various tools in the cognitive, various tools in the physical impairment, and various tools in the psychological impairments. And the treatment of PICS mainly being from the preventive measures, and mainly the ABCDEFGH bundle in the ICU. In the ABCDEFGH bundle, ABCDE mainly raises the importance of preventing the risk factors leading to PICS, and FGH has been introduced to decrease the PICS. Now coming to the Monitor ICU study. So Monitor ICU, it stands for Measuring Consequences of Intensive Care Units in Intensive Care Unit Patients. So this study was done by Wiens and Jiggers. It's a multi-center prospective cohort study which was done in the Netherlands between July 2016 to July 2021. The main objective being to measure the physical, mental, and psychological outcomes and the quality-related outcomes of ICU survivors during 5 years following ICU admission. So this study is mainly a self-administered paper-based or online questionnaire, which where the questionnaires has to be answered either by the patients or the family members. So the questionnaires constitute data belonging to demographic data, health status, physical impairments, cognitive impairments, mental impairments, new symptoms after ICU admission, and the questionnaire has to be answered at for 8 times. That means on the day of admission, while during discharge, at 3 months period, 12 months period, 24 months period, 36 months period, and at 5 years. So the main benefits of the study is so that the study could provide better information to the patients and the relatives regarding PICS. Screening instruments can be used to detect the problems early and to evaluate changes in the ICU care policy so that long-term outcomes could be better, and also for a better guideline development. But the study analysis has not been completed and the study has not been published yet. We have another study which has taken data from the Monitor ICU study. So the study title is Changes in Quality of Life 1 year after intensive care. The study has been done by Porter and Simons. So the main aim of the study is to explore the quality of life before and 1 year after ICU admission in subgroups of ICU survivors. Coming to the methodology, the study has taken data from the Monitor ICU study, and patients who were included in the study were from one of the 11 hospitals in the Netherlands, where the study was done between July 2016 to June 2021. So inclusion criteria of the study is patients who are 16 years or more, and patients who have been admitted to the ICU for a duration more than or equal to 12 hours. Exclusion criteria is patients with short life expectancy, that is life expectancy less than 48 hours, and those patients who do not speak Dutch language. So coming to the baseline data of the patients, so patients who were younger belong to the trauma group, and patients who were older among other patients were majorly belong to the cardiovascular surgery group. And among the patients having comorbidities, patients belonging to the trauma group have lesser comorbidities, and patients belonging to the respiratory disease have more comorbidities. And coming to the ICU length of stay and hospital length of stay, patients belonging to the cardiovascular surgery group had lesser ICU length of stay and lesser hospital length of stay. And patients belonging to the respiratory disease had higher ICU length of stay and higher hospital length of stay. Coming to the procedures, this study, they have taken Euroqol 5-dimensional 5-level questionnaire. This is a very valid questionnaire. This questionnaire included 5 components. So the 5 components or dimensions, which includes mobility, self-care, usual activities, pain or discomfort, anxiety or depression. And each dimension had 5 levels ranging from no problems to severe problems. And this self-administered questionnaire has to be answered by the patients or the patient attenders before the hospital admission. If the patient is getting admitted for elective surgeries or procedures, then the questionnaire has to be answered before the hospital admission itself. But if the patients are getting admitted due to an emergency issue, then the questionnaires has to be answered as soon as possible after the hospital admission. Proxies were allowed. That means when the patient is not in a position to answer this question, their family members can answer this questionnaires. And and these questionnaires have to be filled recalling the quality of life on the day before the admission day. And once the patient is admitted and after he discharges, 1 year after the ICU admission, the questionnaires were sent through an email to the patient or the family members. If the patient or the family member doesn't respond to the questionnaire, the email was sent twice. So among the ICU admissions between 2016 to 2021, overall 12,888 patients were eligible. Among them, only 7,735 patients were included. Among the 7,000 patients, only 5,534 patients have completed baseline questionnaire. And among these patients, only 3,913 patients have completed both baseline and follow-up questionnaire with sufficient data. So they have included only those patients who have completed both baseline and follow-up questionnaire with sufficient data for the analysis. That means they have included only 3,913 patients. So the primary outcome of the study was change in quality of life. And this change in quality of life was measured using Euroqol 5-dimensional 5-level questionnaire. So before the admission, they have calculated the score based on the questionnaires. And 1 year after the ICU admission, they have calculated scores based on the questionnaire. And they have subtracted the pre-admission score from the 1 year 1 year after ICU admission score. So the difference score or the delta score is the criteria. So the minimally clinically important difference has to be 0.08. So the delta score, at least a 0.08 has to be there to be considered as a significant. So if there is an increase in the score of more than or equal to 0.08, then it was considered as improvement in quality of life. If there is a decrease in more than or equal to 0.08, then it was considered as deterioration in the quality of life. If the change is less than 0.08, then it was considered as no change in the quality of life. So only ICU survivors who completed both baseline and 1 year questionnaires were included in the analysis, and the scores have been assessed by means of Wilcoxon's sign rank test. So, so all the patients have been classified, have been considered into 6 classes, 6 major classes, and overall 22 groups. So among these 22 groups, 11 groups have showed an improvement in the quality of life after the analysis. So among the 22 subgroups, some groups have showed improvement in the quality of life, and some groups have showed a decrease in quality of life, and some groups have not showed any difference in the quality of life. Patients which have shown a decrease in quality of life mainly belong to the cerebrovascular accident group, trauma group, neurotrauma, and patients who have shown improvement in the quality of group mainly belong to patients undergoing cardiovascular surgery, post-COVID patients, patients with pneumonia, patients with COPD. And few patients did not show any difference in the change in quality of life. The limitations of the study is, one is recall bias. Second is the pre-morbid quality of life is inaccurate, as just before admission, before the day of admission, most of the patients might have been ill. So the accurate pre-morbid quality of life has not been considered in most of the patients. And this study has been limited only to one scoring system, that is Europol 5-dimensional 5-level questionnaire. But this study emphasizes the importance of raising incidence in PICS and preventing, and the preventive measure starts from the ICU itself, taking adequate preventive measures from the ICU, and which, when continued even in the discharge recovery period, can significantly reduce the incidence of PICS.
Thank you. I'll take first comments from Dr. Bharat.
So a very nice presentation, Dr. Ganga. So I think this study shifts our focus from what outcome you're expecting in general. In our previous critical case study, we were looking at the mortality benefit in almost all the studies. But this study clearly tells us that our focus has to shift from mortality outcomes to monitoring of the quality of life after discharge from the ICU, as rightly pointed to Ganga, which starts from the day of ICU admission itself. We should actually think that the survival is not the best possible outcome, or it is not the recovery, it's probably the part of the job done. So we should focus our outcomes to post ICU as well. And this has highlighted the importance of having post-intensive care follow-up clinics addressing the issues, because there is definitely a gap between the primary physician looking at a patient post-discharge and a critical care person looking at the problems that arise out of critical care, something like ICU-acquired weakness or PTSD and all, and definitely it requires a multidisciplinary approach coming from different fronts like psychiatrist counseling or psychology counseling for the patients, and also especially for the families, even during the stay of the patient in the hospital. That's it from me, madam.
Your take on this, Ghanshyam sir.
Thank you, Dr. Bhavani. Nice presentation. See, the Monitor ICU study tries to look at a very important aspect of intensive care today. We know that critical care is not just confined to the four walls of the intensive care unit, and many of these patients are prone for both physical and mental illnesses, not only during their stay in the intensive care unit, but also once they are discharged from the intensive care unit. And if you look at a large number of trials in the recent times, we have kind of plateaued with respect to various interventions, especially which are looking at at improving the survival of critically ill patients who are admitted to the intensive care unit. I can hardly remember if there have been any major trials in the recent times which have shown to have a significant survival benefit. On the contrary, there is a whole lot of literature which suggests that the patients who are discharged from the intensive care unit, many of them do not go back to their normal routine or what they were before they were admitted to the intensive care unit. So the question of, are we really improving life survival, or are we creating people who are going to be dependent, has always been there. The problem is most of us are confined or kind of concentrate care for as long as the patient is in the ICU. So there is a severe shortage of, one, in terms of what happens to these patients once they are transferred to the wards or from there to homes. How should one take care of this? What is their quality of life in terms of both physical, cognitive, and mental abilities? And how do we actually take care of this? Who should be the people who should be involved in taking care of this subset of patients? Because there is severe limitation or a shortage of both literature or guidelines with respect to all these parameters. And if you look at the recent ISCCM guidelines, one of the position statements was dedicated to addressing these issues. See, most of us believe that the concept of post-intensive care or the quality of life comes, or the question arises once the patient survives and then is transferred out of the ICU. What one needs to understand is the post-ICU syndrome is something which can start within 24 hours of admission to the ICU. For example, if a patient is admitted to the intensive care unit, then these changes can happen within the first 24 hours, and they can last as long as almost up to 15 years. And it not only affects the patient, but also affects the caregivers in a significant way. So with respect to that, though this study was initially aimed at looking at what happens to these patients at the end of 5 years, they did, I think, only from one center, they tried to look at the quality of life post 1 year. So I think given the current scenario that we are, and as intensive care specialists, I think this is an important study which emphasizes or suggests that all of us should look at what happens to the quality of life to patients who get discharged from the intensive care. And it's not just about survival anymore. Survival, over the last many years, with good quality intensive care unit, we are having a significant increase in the survival rate. But are we justified in just keeping them alive? And what's actually happening to the quality of life is something that we need to seriously look at. So in that regard, I think this is an important study.
Yes, sir. I agree. Srinivas sir, what is your experience and does it really correlate with this study that we are talking about?
Our experience, I can say that we did not do such a structured approach. We just followed up our patients when we and Ghanshyam started critical care in 2006. From then on till at least I can say till 2019, when COVID, just before COVID, we have follow up of quite a big number of our patients. We always have felt that while there are structural problems like cardiac dysfunction, limitation of exercise ability, there is respiratory insufficiency, there is peripheral nerve weaknesses. These are all structural problems, but psychosomatic problems persist for years together, even as long as 7 years is what I have understood. But as Ghanshyam already has said, and as the speakers also have said, it is not just the patient who suffers from these psychosomatic disorders. The patients definitely have nightmares. The patients usually quite often have unpleasant recollections of their experiences in the ICU. But what happens is the person who was attending to the patient continuously while in the hospital undergoes a post-traumatic stress disorder. And that patient, the family member of the patient actually extrapolates some of the diseases to himself or herself. Or I think it should use the word themselves currently in the current context of gender neutrality. So suppose there was a patient who had come with heart failure and he was on ventilator and the relatives were looking after. The person who was closest to the patient somehow, for every trivial symptom, he tends to see that he has heart failure. So this kind of cognitive post-traumatic stress disorder happens in the caretakers of patients who have stayed in the ICU for a longer period of time. And as practitioners of critical care, we tend to have some quality metrics, like we have abnormal deterioration, unexpected deterioration, readmission into the ICU within 48 hours, or re-intubation within 48 hours of extubation. All these are our quality metrics in the ICU in the acute phase. We have failed to capture the chronic metrics, and this one is probably one of the important metrics we need to capture if the quality of our intensive care has been good or bad for the patient.
Yes, sir. Most of the time, like in our practice, we usually follow up the cases. We don't follow up all the cases out of the ICU till discharge. Some of them, yes, we do. And after the hospital discharge, I don't know how many of us really actually follow it up, like you have been doing till 2019. So that becomes an important part because some of them usually come back.
Navina, we are losing your volume.
Can you
Navina?
hear me, sir?
Yeah.
Hello? Can you hear me?
Yes, ma'am. Yes, ma'am.
Yes, sir. So we do usually follow up the patients after the ICU, not many of us and not all the patients. So that is actually challenging to follow up after discharge from the hospital. And as we went through this study, we even went through that post-intensive care actually starts within 24 hours. So what are the measures that we can take that will actually reduce this kind of a burden?
Umar, are you asking the question?
You can answer, sir.
I can answer. Yeah, fine. See, just as when you intubate a patient, when do you start weaning a patient from ventilator support? When you intubate the patient. When do you start weaning off vasopressors? When you start them. What is your plan? Right? When do you plan to wean off RRT? When you start RRT. So how do you expect to prevent post-intensive care syndrome is when you bring the patient into the ICU. So if the patient is conscious, you have to explain to him why he is in the intensive care unit, what you are going to do in the intensive care unit. who are the team members who are going to look after him. If that rapport can be established, I personally feel it will lighten their stress response. Most importantly, the family who is anxious, who is stressed out already. We need to sit them down, have a calm discussion with them, introduce the team members, explain to them what every single gadget and every single intervention in the ICU is going to do for the patient, and what realistic expectations they can have from the interventions which are being done, and be transparent and upfront with them. So that will actually give that confidence in you for amongst the family, and then they will probably be less stressful, and they will also be happy or convinced with the idea that somebody who knows what the plan B, plan C is, for the next 24 hours, what is going to happen. Somebody who knows what he is doing is actually in charge of the patient. We need to take these proactive measures at the beginning of ICU admission if you have to prevent the post-intensive cases.
Okay, sir. Ghanshyam sir, any pharmacological therapies that you use which will help for them to maintain their day-night difference and other cognitive functions?
I think one of the key aspects, at preventing the cognitive dysfunction is to understand what are the modifiable risk factors and what are the non-modifiable risk factors. If you look at certain factors which are under our control, especially the kind of sedation you use, for how long do you use the sedation, whether the patient has delirium or not, how good is your pain relief. These are certain very, very important factors which can lead to significant post-intensive care issues, especially with the with respect to cognitive aspects. Similarly, most of us tend to forget or tend to kind of ignore taking a detailed history of whether the patient had any such issues prior to admission to the ICU. Right? Most of us don't actually give a lot of importance to try and see if the patient had any psychological issues, if the patient had any addictions, if the patient had or what kind of a quality of life the patient had, and those things are extremely important. Now, do I use any pharmacological interventions? See, the most commonly used intervention is the sedation and the analgesia that we have with us, because almost every patient who's in the intensive care unit needs this. If you look at this study as well as other studies, there seems to be a direct correlation between the severity of the disease and the incidence of the post-ICU syndrome, right? And among a lot of conditions, severity of septic shock, patients who have been on mechanical ventilation, ARDS, now these are the subset of patients who seem to have a very high risk of post-intensive care syndrome. Yes, obviously those other conditions like patients with neurological dysfunctions as well. So how do you give your sedation becomes extremely key. How do you give your sedation breaks become extremely key. How do you wean these patients become extremely key. What happens to your patient-ventilator asynchrony becomes very important. If you have patients who have been having psychological issues or who have been having addictions, yes, we do take the help of a psychiatrist where we do add some antipsychotic medications. Sometimes I also use melatonin agonists to kind of induce the sleep cycle. So far, experience has been fairly good. But the key for us is we don't use benzodiazepines as continuous infusions, because there is a direct correlation between the use of benzodiazepines and the incidence of delirium. We use a lot of alpha-2 agonists along with opioids. When not needed, don't use it. I'll just give you a practical example, right? Right now, I have a patient who's admitted with me. He's a doctor. Unfortunately, met with a bad road traffic accident. Had a massive extradural hemorrhage. So taken up for, had multiple facial fractures. Taken up for came with a low GCS, taken up for an emergency surgery, intubated. Now he has significant conjunctival edema, so unable to open his eyes, right? And obviously he can't speak, he can't communicate to us through his eyes. So you are worried about what's going to happen to the post-ICP, intracranial pressure, so you have been sedating. We did an MRI of the brain, about 48 hours down the line, 72 hours down the line, found that there was no significant major injury suggestive of diffuse axonal. He was being very restless, so again, the cycle of sedation, everything started. So one day we decided that we'll stop everything, kind of tried to talk to him continuously. And then we realized that he is conscious, he is able to understand us. But the only two ways of communicating to us through his voice, he could not do it because of the ventricular tube, and he could not communicate to us through because he was unable to open his eyes. So such simple measures can sometimes actually tell you that, you don't need to give them a lot of sedation, or you don't need to give them a lot of medications that we normally give in our patients. So one, constant communication. Yes, do not hold back if the patient has any pre-existing psychiatric issues. So do not hold back in using those medications, especially in today's the lifestyle that we are leading. A lot of us are seeing patients who are alcohol dependent or who are exposed to drug abuse. So these patients have a very high incidence of going into withdrawals. So don't hesitate to use or take the help of a psychiatrist and use some medications which can help you counter these effects. I'm sure most of you would be seeing a higher incidence of alcohol withdrawal in your patients these days as compared to what we used to see in the previous.
Yes, sir. Even smoking actually, and some of them actually are helped with the nicotine patches that we can actually put on them once they are extubated.
Navina, I want to say something here. Hello? Navina?
Yes, sir.
Yes, we can hear you.
Yeah, so in my last 6 months or 8 months in my last hospital, I tried live music therapy. Okay. There is a course in medical music therapy in University of Chennai, in Madras. The Madras University runs an MSc PhD program in medical music therapy. A very good PhD teacher, Dr. Ansuya Ngirala. She is a classical Carnatic singer. She is the course director of this program. And we tried to bring, and her students were actually coming into the ICU and singing with the patients. Even if the patient had hepatic encephalopathy, patients who were on, one of them was an ECMO. There was a patient who had a stroke. Twice a day, 8 to 10 minutes of physical singing dramatically brings down your sedation dose and actually wakes these patients up very fast. This is my experience. We wanted to publish it. Good data. We had about 60 to 70 patients. They had a good analysis. One of those PhD students actually wrote her thesis on this. I wanted to present it, but unfortunately I left the hospital and I couldn't use the data. But it is something, it is going to be the future of non-pharmacological management of delirium in the ICU. And abroad, there is something called as canine therapy. You bring in trained therapy dogs into the ICU. You get good Labradors, golden retriever, goldies, beagles. These dogs are trained to actually give that sense of well-being and happiness to patients who are delirious, and they have shown to reduce the dose of sedatives and hypnotics which these patients actually get.
So how about allowing their own pets into the ICU, sir? Hello?
Just as a family member gets distressed by looking at their family member on ventilator with tubes and pipes, animals also get upset. Okay, we a human being may collapse there and start weeping in the ICU, but a dog, a cat, a parrot, even a calf would stop eating if the animal sees its friend or its family member. They can pick up people who are ready to die earlier than what we can. That's the knack which an animal has. So if they pick up that cue that this friend of them is going to die, they will stop eating. So you can cause more psychological harm to your own pet if you allow them to come into ICU. And these therapy dogs and animals are actually trained specifically for this purpose. So any pet cannot walk in and give that comfort to the patient.
Very interesting, sir, actually. And we actually recently had a patient in my ICU, sir, where he actually got admitted with a fever because of this viral illness right now. But he was admitted a year ago for septic shock. He was in the ICU for a week. And so now he complains of forgetfulness, his decreased cognitive function, as he was actually telling his history. So how can we help with this once patient is out of ICU and he is in the room and not yet discharged from the hospital?
I didn't get the question actually.
How can we help him after discharging from, before discharging from the hospital, but out of ICU in the room?
See, I think one of the key aspects for all of us is to first identify or recognize the fact that these patients can go through something like this. Right. Second thing is, a significant amount of care is, I wouldn't say compromise, but the intensity is lost when you're transitioning a patient from the intensive care unit to the wards. For example, something like nutrition, right? Now, when you look at patients who are in the intensive care unit within nasogastric tube, or if somebody is on a parenteral nutrition, there is a very close monitoring about what's happening to your enteral nutrition delivery. And many a times when we are extubating patients, we have a tendency of removing the NG tube as well. Now, what happens to the patient's oral intake? Because a significant number of these patients can have dysphagia. A good number of patients may not have appetite. There could be early satiety. So their oral intake may be decreased. But there could be a psychological bias that, okay, the patient is extubated and he will eat. How many of us actually go back and see how much food he has eaten or taken orally? Second thing is, again, if you see, I'm not sure how things work in different hospitals, but most of the times the food delivery is at fixed hours. You get breakfast at a specific time, lunch at a specific time, and the dinner at a specific time. And it does not necessarily mean that the patient is hungry when the food is there. There should be something called as an on-demand service. Whenever the patient feels hungry, you try to feed him then. Whenever the patient feels like eating something, you need to have a facility of feeding him then. Right? Sometimes you need to combine your nutrition with your rehabilitation. For example, somebody is undergoing a physiotherapy. There is a higher probability that he may feel hungry after the exercise. Similarly, your protein assimilation is better after an exercise. So you need to make these subtle changes. Similarly, the fact that these patients can have both cognitive, physical, and mental disabilities is something that should be recognized by everybody. And there has to be a comprehensive multidisciplinary team approach, which includes your intensivists, your primary care physicians, if required, a psychiatrist or a psychologist, and depending upon your own assessment, maybe a neurologist, etc. And there has to be a definitive follow-up. Now, how should the follow-up be? How frequently? What are the post-ICU tools that you would use? Now, there are multiple tools, whichever suits you can use it, but that has to be clearly defined, or at least that has to be mentioned and discussed with the family that these are the possibilities that a patient can have, and hence they need to be under the follow-up. They need to be under the follow-up so that you can identify and pick up these things early, and maybe put them on some kind of a rehabilitative support.
Do you mean follow up with the intensive care unit?
Follow up with whoever is, see, we do not have a formal structure of post-ICU clinics in India. I don't know how many centers across the country have a well-defined and a structured post-ICU follow-up clinic. So it all depends upon the kind of infrastructure you work, the kind of rapport that you can have. What I have done in recent times is wherever we have a very sick patient, and when the patient goes out of the ICU, we keep a follow-up in the wards. At least once or twice, we just go and check on what's happening and whether the few things that we did in the intensive care unit, are they being continued? Especially two things that I generally keep a watch is the nutritional delivery and the physical rehabilitation, whether they are going to some kind of a rehabilitation protocol or not. And I tend to keep interacting with the primary care physicians, trying to impress upon them the need for further follow-up. So either I get a feedback from the primary care physician or the patients come back to me, to just meet me after their recovery from the intensive care unit. So till we define, until we have a very structured clinic, I think it all depends upon what you do at your individual institute level. The best thing is, because we as intensivists deal with these patients, I think we need to be sensitive enough, and we need to kind of keep talking about this with our colleagues so that the care is continued.
Yes, sir. Dr. Bharat, your take on this?
Yes, ma'am. As sir was pointing out, we actually need to monitor a few things which we tend to take it for granted, like giving sedation whenever the patient gets a bit irritable, increasing the dose of sedation, or neglecting the past psychiatric medications or any addictions. Then I actually would like to add a point on awareness. We generally tend to avoid even giving local anesthesia while putting lines if the patient is sedated, paralyzed. But recently I had an experience with an educated patient wherein they actually are able to clearly recollect and tell us what we are discussing on the bedside in our day-to-day rounds, and even what we are discussing with the staff and all while doing procedures like putting a central line or an arterial line. And they were actually able to recollect it very clearly, word to word, and they're able to tell us. So which actually highlights the issue regarding the awareness. Like, it was all highlighted in our anesthesia days, like awareness and anesthesia, but there is awareness in the patients too, and which definitely would carry on and good impact on the long-term outcomes, especially while we are doing our rounds on the bedside. Like, we'll be taking our input from all different members of the team and discussing about the case and all. Probably, I think it should be done far away from the bed, even if the patient is sedated and paralyzed. Some things which we do not want to break upon them at that point of time. As I was telling, we have to tell them clearly what we are going to do. And if they are educated and they're sound enough, many patients are actually, after we have started the same thing, like we're decreasing the sedation requirements and we're trying to communicate. If they're well literate, we're giving them a piece of pen and paper where they can write and communicate to us clearly because of inability to speak with the tube in their throat. And I think rest of the things, as sir pointed out, I would agree to all the points. And maybe especially we also have to consider the family, which would be in grief, because most of us will spend a few minutes with the family during the time of counseling only, I think. So probably having a social worker who can coordinate with the families and us would actually be increase the trust of the family upon us, because they'll be explaining them what all our needs, what we are communicating to them. Probably they can spend some more time together knowing about the family and supporting them psychologically. And most of the times it will be much easier for us to do the counseling with the trust of the family. Often I've been seeing the patients who do not trust us and always ask us whether the patient is live or the patient is already dead and you're treating a dead patient. Probably in such cases, having a social worker or somebody from the team, maybe a nursing staff or some other person who was actually not allocated any particular duty inside ICU, because they cannot leave their ICU duty and go and do that. So probably social worker would justify. They can start having the rapport from day one, which actually gives best results in the way we support the family.
Just want to add a couple of points here. As Bharat pointed out, something that I have seen very commonly is the tendency of many of us to use paralytics without actual sedation, without giving them a deep sedation.
Yes, sir.
There is a tendency for people to use paralytics whenever the patient becomes restless. That is something that you need to avoid. And second thing is, see, when you're having a big team of intensive care, okay, sometimes families develop rapport with certain consultants or certain residents. Okay, and I make it a point that if a family is very comfortable with one resident or one consultant, we tend to allow that consultant or that resident to communicate continuously or be in touch with their family who can communicate about what's happening. It need not always be that as the head of the department or consultants, only you have to do the talking.
Yes.
Sometimes you may not be able to develop that kind of a rapport. Sometimes, some people have a natural tendency of developing a rapport or connection with certain families. So just allow that to happen.
Yes, sir. Even this practice of sometimes when we put lines immediately after intubation, some of them usually don't give local. And that also, I feel I have seen a patient telling later on that he had a pain while putting the central line. So that also, I think probably we should take it into consideration. Another thing, sir, Srinivas sir, I want to know what would be the role of an intensivist in the future, in the upcoming post-intensive care rehabilitation or the follow-up clinics. What can we do about it?
All right. See, one thing is to understand the structural consequences of critical illness. Now, especially if the patients have been on mechanical ventilatory support or on extracorporeal support or on RRT, the long-term consequences of these interventions can last up to 4 years to 5 years. So, an intensivist should be involved in screening these patients for potential long-term consequences. For example, if somebody had one episode of AKI in the ICU, whether he required RRT or not required RRT, up to 5 years he has a risk of developing CKD. And the intensivist should be involved in the care of such patients because they know what has transpired during this patient's stay in the ICU. That is the physical aspect. The second aspect is that, as Bharat has said, and we have already, we have seen that before also, that patients, you stand at the bedside of the patient who's undergoing CPR, and you think he's gone. And then you say, poor guy, he was such a nice guy, you're always friendly with us and all that. That discussion is actually being heard by the patient. 40 to 50% of the patients can actually identify the voices which were talking positively. They can identify the voices which were talking negatively about their outcomes. So the intensivist should be able to build and consolidate that rapport. Suppose there is a patient who has come with a bad peripheral vascular disease, cellulitis, gangrene, septic shock. We have resuscitated the patient and he undergoes an amputation. And post-amputation, he goes to the room. The intensive care team is the one which should be taking the lead in speaking to the patient and getting him out of the psychological stress of losing limb. Because we are the ones who had the best rapport with the patient during his acute phase of illness, and we are the ones who have actually got into that phase in his mind when he was sick. We are the ones who stood with him. So we should be able to help the primary teams in bridging that gap and accepting the adverse outcomes for these patients.
So do you use any medications like melatonin and others like modafinil, sir?
In the acute phase?
No, after recovery phase.
They'll have minimum role in that. If you can counsel the patient, see, the most important cause of such cognitive dysfunction is the loss of day-night differentiation for the patients. And if you remember, all our tracheostomy patients who were able to mobilize used to go out in the corridor on a wheelchair, right? So we need to make the physiological circadian rhythm come back to normal. If you can do that, all the pharmacological measures actually don't come into the picture. Most of them, maybe 1 out of 10 patients, my use of these drugs is very, very less. And I mean, I don't know. Ghanshyam might be using them. I don't know, but my experience it has been if you can get the diurnal circadian rhythm going, you can calm them down, give them the best music they want to hear, keep one trusted family member or aide along with them. I think, and as Ghanshyam said, one of the common things that produces delirium and agitation among patients is hunger, which we don't recognize. So if you can take care of that, I think we can sort out most of these problems.
So I think like intensive care is moving from ICU survival to hospital survival and then to a
No,
post.
no, no. No, no, don't say intensive care is moving from. Intensive care is also involving post ICU care. We continue to do our bread and butter intensive care. We still make blood go round and air go in and out. But still, even after the blood is going round and air goes in and out, we will still follow up these patients. It's an addendum to our repertoire of deliverables. It's not that we are going out of the ICU and doing post intensive.
Just to add to
Yes, sir.
who should be taking care of this, I think intensively should lead this. Okay, because we are the
post-intensive care clinics, follow-up clinics.
We should be leading it, and I think we all should get into the mode of becoming physicians, clinicians. I won't say do general medicine, but start thinking like a clinician. Start, following these patients because you are with the patient during the most difficult times of the patient and the family. Right? The kind of bonding that you can develop with the patient and the family, you generally say, there's a saying that you bond well during tougher times. And we need to take that advantage. And I think with respect to post-ICU clinic, it should be the intensive care who should lead. Yes, you should take the inputs from different primary specialties. The patient had a primarily, say, a COPD patient who has come to the intensive care unit. You take the help of a pulmonologist or whoever was the primary physician, but you should make it a point to see these patients.
Okay.
It's very important. Certain inputs that we can give, I don't think, not underestimating any primary care physicians, but I think they tend to miss out certain points.
Because I feel we spend more time with them comparatively.
Because you read about these things. This is something that is a core aspect of your patients.
Yes, sir.
Patient going into depression, anxiety is something which you would know, having seen the patient go through a very stormy course in the intensive care. And you can predict whether the patient will go through anxiety, depression, whether the patient would need psychiatry, the patient presents to you with subtle signs and symptoms suggesting that he is having cognitive dysfunction. I think as an intensive case, you are somebody who should be able to pick it up.
The understaffing in the ICUs is again a challenging issue when probably it comes to these kind of things like mobilizing them out in the wheelchair and all, sir. I feel like, it has decreased comparatively because of the understaffing.
This is always going to be there.
I'm not sure if it's everywhere, but I feel that's the thing.
No, that is only one aspect. We can't say it's only because of that reason.
No, it can be
It's
understaffing.
not happening, right? It could be one of the reasons. It could be one of the reasons, but it is not the only reason.
Yes, sir. And
it is not, and it cannot be the only reason. Yeah, it could be one of the reasons, but then again, you can always work around that, right?
Agree. It is one of the reasons, and the other reasons being like these days you really don't think of building so much of a rapport with the attendants because of the things that are going in and around. Like you see, sir, it's little scary sometimes to actually.
I can tell you something.
Yes, sir.
Bad incidents happen across, but that doesn't mean that they're happening with everybody. See, I'll tell you my personal experience. One of the things which builds trust is when a patient walks into the intensive care unit and he doesn't find any doctor there. Right? If you find that, especially during the visiting hours, right?
Yes, sir.
You need to have your sisters, nurses, doctors in the ICU during the visiting hours. The families, it is only one of the aspects. I'm not saying this is the only thing, but if I am walking somebody, suppose my kith and kin is admitted to one of the hospitals, some other hospital, and I just walk in and I don't find any doctor or anybody there, then I'm sure that we all have our own doubts.
Right. I agree with that.
And there should be somebody who can talk and explain to them what's happening.
Yes. Dr. Bhavani, coming to you, what is your take after presenting this trial and your further measures that you're going to take in the ICU? Your take from this trial.
Definitely, it has changed my perspective because post-discharge, the patients have to, it doesn't start from the discharge actually, it starts from the ICU itself, from the first day of ICU. So taking all the measures to reduce the risk factors, which leads to the incidence of PICS. So when we consider all these risk factors, and if we could definitely decrease the incidence of PICS, then definitely we would do a better job, and it will definitely leads to a better outcome to the patients.
Your closing comments, sir, Srinivasa?
Comments, right. So, as I said, when a patient comes to your ICU very sick, your priority is to get the hemodynamics right, the acidosis corrected, the coagulopathy corrected. But at the same time, understand what the patient is going through. Put yourself in the patient's position and the family's position. And as Ghanshyam said, spare that time. Give them the impression that you are there when the patient needs it. If we can do that, we can relieve a lot of this post-intensive care psychological disturbances the family and the patients will have.
Ghanshyam, sir?
See, post-intensive care syndrome is a reality, right? And there is it's only going to increase with the kind of patient load we are seeing, with the kind of lifestyle changes that are happening. It is only going to increase. I think we all should be aware of it. We all should be, key leaders in leading this aspect of care for patients who get discharged from the ICU. And as we all agree, it's not something which we should be thinking about at the time of discharge or at the time of transferring the patient from the ICU, but right from the start, the patient is admitted to the ICU.
Thank you, sir. Thank you, Dr. Ganga Bhavani. Thank you, Dr. Bharat. Thank you all for joining us. Please do subscribe to our HICS YouTube channel, and we'll see you next month.
Thank you, Dr. Bhavani. Thank you, Bharat.
Thank you,
Thank you,
sir,
sir.
for the opportunity.
Everyone, have a good day. Bye bye. Have a good weekend.
Thank you, sir.